So it's kind of at this time of year when Saturday night television talks to us about the journeys that contestants have been on as part of joining in some celebrity or I want to become a celebrity type thing. So if you'll indulge me, I would like to share my reflections on the FFT journey over the past 18 months from my perspective in the centre of NHS England dealing with the policy for all of this. So we inherited the policy for the Friends and Family Test back in April 2013, and when we picked it up, it kind of came with a lot of criticism. There was an awful lot of enthusiasm in some parts for it, but also there were articles in the HSJ about how it wasn't going to be valid. There were academic kind of criticisms about it's not going to be statistically robust. How can it be used for the purposes that it's intended to be used? So it kind of got off to a bit of a rocky start, and because we'd inherited the policy, we decided we would do a review after 6 months or so to see how is it working, what can we do to improve it. So what did that tell us? Well, it kind of told us that FFT was having a bit of an identity crisis. I remember coming to one of these earlier symposiums and people standing up here talking about FFT going to be a thermometer. You can take the temperature of your how patients are feeling. It's a can opener through which you can uncover further kind of evidence about what's working. The PICA policy report of FFT, which was published a few months ago, talked about the weight of expectation that was on FFT as a patient experience tool. It was supposed to be a metric for quality, a tool to indicate choice, a performance measure, and also a tool for service improvement. So it had an awful lot of expectation riding on it. And one of the key messages from the review was that in our communications as NHS England, we ought to be clearer about what's its purpose. And I think now we're really clear that its purpose is predominantly for service improvement. That's where it works really well. That's how people have gotten to grips with it. That's what makes it come alive. That's not to say it can't be used for other things too, but one of the things we're super clear about is that it's not a statistically valid performance indicator in the same way that other surveys are. So, for example, in our communications, you won't hear us refer to it as a survey because that kind of comes with connotations of the other surveys that we look after, so the inpatient survey, community mental health, and they have really valid and important roles to play. They measure really well and really robustly how much different national policies have made an impact in terms of patient experience, but they're less good at being locally owned. The processes that they go through make them suitable to have financial incentives attached to them because they are weighted. We can look at them for non-response bias and things like that. But the data comes out quite a way after it was originally gathered, which means that perhaps it feels like there's less local ownership on the ground and in trusts. So I think what's clear is that FFT does something very different from that, and that's okay. What else? I think there's something in FFT which is about the volumes. When we think about the volumes of people that give feedback, I think we're at 3.7 million pieces of feedback now. When you compare that to the national surveys, one of their weaknesses perhaps is that they don't really account for every patient voice. I think particularly in community and mental health that has a number of respondents that I think was 13,500 this year, which is not very many when you think about the numbers of people receiving those services. Maternity is something like 23,000, A&E 46,000. So this FFT thing is about hearing from lots of people and hearing from all kinds of different people, not just people that are adults, that are British, that can understand a written survey. Another message we got loud and clear from the review was that the Net Promoter Score just wasn't liked. I don't know if that's your experience out here. People didn't understand it. People didn't know how to explain it to patients. People didn't know how to explain the results to staff. It's a kind of a bizarre, it's just a figure, isn't it? Anywhere between minus 100 and plus 100. So making sense of that figure was proving to be quite difficult. So I don't know if people have looked at NHS Choices recently. So now we've got the transparency scorecard that was published, I think, a few Fridays ago, and we had our first publication of staff FFT data, and those are now presented as positive percentage of people that would recommend. Another kind of criticism of the Net Promoter Score was that the people that had responded likely weren't counted. Why is that when they have put a positive response? Why doesn't that get counted? And also the people that have responded don't know were taken out. So we've moved into a much simpler representation now of the results, where the likelies are included in the positives, those people that would recommend, and the don't knows are included in the denominators. On Thursday this week, we have our next publication of patient FFT data, and for this month only, it will be published as the percentages, the percentage who would recommend and also the percentage that wouldn't, because it's quite important to keep an eye on what's happening with those that wouldn't recommend. Is it because they really strongly feel that something was wrong and they put extremely likely? Or is the balance, you know, the number that isn't the positive recommender, is that because people don't know or they put neither nor? It will also be publishing the Net Promoter Score for the last time on Thursday. This is because there might be people, and I find this wherever I go, as much as we found in the review that people didn't like Net Promoter Score, some places have really got to grips with it. They're reporting, they're using it, their boards understand it, they quite like it. There's nothing to stop people from doing that going forward. We haven't changed the response options, so it's still quite possible to keep understanding your results in terms of Net Promoter Score if you want to, but we won't be publishing them like that after this Thursday. So the review also tried to look at where does it work well, and it was working well when it was locally owned. And I think it's understandable at the start. People were nervous about the feedback they were going to get. If there's a feedback sheet from today's event and you're asked to give feedback on me, I know I'm nervous just thinking about what you might put. So it's totally understandable. It's a human nature response. People were nervous about that. They were anxious. I think the review found that, sorry, I just got distracted. The review found that overwhelmingly the feedback people were getting was positive. About 80% or more of the feedback was positive. So I think that started to make people feel a bit more comfortable about what it was that was happening. Why is this a useful tool? And in some places where it was working really well, it was being embedded into processes as part of everyday ward management, for example, looking at last week's feedback in this week's team meeting. What can we do about that? Started to generate an appetite to hear more feedback. For example, in the Royal Orthopaedic Hospital, I'm aware that they're using FFT as part of their revalidation processes, so consultants are getting feedback from patients. The review found that 78% of trusts felt that FFT increased the focus on patient experience within their organisation, which is no bad thing. I think it's a case of how to do it and being open to understanding what it's like to be on the receiving end of us as a service, because when we're continually on one side, it's quite easy to forget what it's like to be on the other side. And this is part of becoming learning organisations, I guess, and being continually reflective. So what else has happened? We also inherited the mandate commitment to roll out FFT across other NHS settings, and that's kind of what we're on the verge of at the moment, isn't it, with GPs going live in December and so on. So we had a job to do in terms of what would the guidance look like for that. We had a number of early adopter sites and also some pathfinders, and if any of you were early adopter sites or pathfinders, we're very, very grateful for you, for your participation in that. And we had gut feelings that what the design of the policy was in inpatients and A&E wouldn't directly translate easily into these new areas, and that's for a number of reasons, but some of them are that patients just don't follow the same pathways in places like community health services and mental health services. They see a variety of different clinicians over a much longer period of time. Perhaps they never get discharged. Perhaps they never go into an NHS building. So how does that impact if you've got posters on the walls saying, please give us some feedback? We can't go into patients' homes and put posters in their hallways and ask them to pop things in their, for the front door. And there's also something about the organisations. So when we spoke to community health trusts and mental health trusts, and we had ideas about how does the policy work, quite unanimously they would come back and say, we don't work like that. We're different. We're structured differently. We have different types of services. So we felt overall that to mandate a particular way of doing FFT would really not serve much purpose other than generate a lot of backlash around this isn't going to work for us. So that's why there's a lot more flexibility in this guidance. And talking about the guidance, you'll have noticed, I'm hoping if you've read it, that it looks slightly different, and we wanted to do that on purpose. Much like a contestant in the X Factor, it has had a bit of a makeover. It might have had its teeth whitened, it's got a new wardrobe. And seriously, we'd be interested to hear your feedback about that guidance, because that was a very deliberate move on our part to get away from a kind of Word PDF to something that was usable, had clips and practical tips, as well as being usable depending on where you were coming from. So very happy to have feedback on that. So you'll see in the guidance that the timing is flexible for those new areas. We haven't said when you're to ask patients, because there might not be a standard good time for that to happen. That's down to you locally decide when you'd like to do that. For example, in mental health, a lot of the discussions have been about linking it to the CPA process. So when you physically have the patient as part of their care plan assessment and the review, maybe that's a good time. On the flip side, I've heard an argument that says, well, actually, there's already a lot to do as part of that process. So how can we not burden that part of the process with something else? How can we do it at different points? So I think we're happy that you can decide locally when you proactively ask, but the underlying principle, which is a subtle shift from the original guidance, is that instead of requiring all patients to be asked at a certain point, it's about the opportunity being available for people to leave feedback whenever they want. On top of that, you could choose to, proactively reach out at certain points in the pathway or at certain points of regularity, but still with the mindset that this is a real-time feedback tool. This isn't a scheduled thing asking about an experience 6 months ago. It's you've recently been in to see us, or you've had an interaction. How was that for you? We want to know quite soon afterwards. It's still anonymous. That's quite key, and the reason for that is that it's really about honesty and being able to get honest feedback. We've softened the position, I think, a little from the original guidance, which said that anybody that was involved in giving care to the patient shouldn't really be involved in the FFT. We recognise that because the new guidance is all about hearing from everybody, and that will include children, it will include people with learning disabilities, people with dementia, people with other communications difficulties. Saying that the person that was involved in that person's care can't take part in this might not be the most appropriate thing. It might very well be that the person who is best to start that conversation about getting feedback is the person that's got that trusted relationship with the patient. For example, I think with feedback we had from dementia specialties was that, for example, a phone call from a stranger once the patient is back home can be very unsettling, because they don't know anything about it. They can't quite calculate in their head what this is all about. So that seems very practical to me. So there's an awful lot of flexibility, and I recognise that might be disconcerting for some people, because we in the NHS we're very used to saying this is how things ought to be done. And I think what we've tried to do here is be clear about what the point of this is, what the aim of this is, what it can be used for, how you can make the most of it, rather than telling you explicitly how you ought to tackle it. I think I've been to a few sessions to kind of kick off FFT in the past week or so, and there was a real learning point from a session I went to a few days ago, which is that this ought to be started with a discussion between providers and commissioners. What's appropriate? What's going to make sense in the particular services? We're very clear in the guidance that this is a real-time feedback tool. Therefore, it might not be appropriate for some patients. If a key part of your service is people who are having crisis, then this isn't the time to be asking them if they'd recommend the service. Obviously the focus is about their recovery. So that's okay, and I think it's about agreeing that then with your commissioners, but still thinking, how can we continue to hear from these patients if it's not through the friends and family test? So I'm conscious of time. We are still finalising some parts of our guidance. There are some bits of things that are missing. So, for example, the dates for submitting data in the new settings, we're still working on those, and we're hoping to get the guidance out for that, I think at the end of October, that kind of time frame, and also a bit more detail of what that will look like. But essentially it will be how many people responded in which category. So how many people said extremely likely, etc., etc. And how did they tell you that? Was it through postcards, SMS, telephones. Obviously the big change now is that tokens are a no-no, and that's really because you can't really attribute feedback, real-time, the free text feedback to the tokens. So like any good X Factor contestant, FFT has got a team of people around it. It's not just itself. And locally, you'll have regional teams. I don't know if any of the regional teams are here today, but there are regional teams whose purpose is to support you through implementation. There's a list of names and email addresses in the back of the guidance on one of the very last pages. So I'd encourage you to make contact with your regional contacts if you haven't already. And I think one of the challenge now is about, we've had lots of examples, and if you're already doing it, I'd be really keen to hear from you about how is it making a difference in your trust. We're all ears to that kind of information. But how are we taking it from teams, smaller teams, making improvements? How are they spreading that across their organisation so that the whole organisation can learn and understand what's making a difference here? And also now we've got staff FFT, how can we triangulate that data so that we are giving our staff the same rights to give feedback and for us to act on it that we are giving patients.
Parker.
Thanks, I'm Parker from Virgin Care. So we've used friends and family in an outpatient setting. We've found it quite challenging to get patients. This is an out-of-hours service, so we've found it challenging to get people kind of in the evenings when they're feeling quite sick to take the time to do it. We're also looking to roll this out in our community nursing services, and I think the change that you've made to allow the carer to engage with the patient should really, really help us, because the feedback we've been getting is a lot of our frail and elderly patients, end of life, just wouldn't engage on their own, so that should make a big difference. I'd be interested in hearing with anyone who've had success in getting good uptake in very busy out-of-hours centres in kind of deprived parts of the country, where just getting people to not rush out the door where people have had success with that.
Off the top of my head, I don't know of any, but I can imagine it would have similar kind of feel about it as A&E. People hadn't expected to go in, they just want to go home at the end of the day, so I can imagine it'd be quite difficult. So I know some A&Es that have really gotten quite good responses, and that's been by using something like SMS or something, so not whilst they're in the physical building, but after they've left.
The difference is in these walk-in centres, they're anonymous services,
yeah, of course,
as well, so we don't even have that.
Yeah. It's a challenge, I acknowledge that.
I'm a practice manager in a GP surgery, and just wondering if the core question set can be changed at all. Particularly, is it easy to get an appointment? Because we operate a triage system, so the patients may not need an appointment necessarily. So can that one be changed if you run with you?
Yeah, so I don't think there are any mandated questions other than the how likely are you?
Right, okay.
And the free text follow-up question. So you're at liberty if you want to ask more questions on top of that.
Or take one out. Take that one out.
I'm not sure. I'm not aware of any being in there. Certainly not in our guidance. That, as far as we understand it, though, it's just that question and the follow-up text question.
Right.
So if there are things you want to ask, that's fine. If there aren't, that's fine too.
Okay, thank you.
Any other questions at all? Or all your questions have been answered now? You're still confident you're going to move forward? Well, Claire's very kindly agreed to be around you then. I know sometimes it's easier on a one-to-one, but as always, our colleagues in NHS England are as keen to learn from you, because you're on the front line making it work. So I'd just sort of like to thank Claire for your time today and for being here today and answering questions later during the sessions. Thank you very much.
Thank you. Cheers.